Thank you very much for the kind invitation. Again, it's very honor to come and share my experience in this very prestigious meeting. So my topic is diffuse disease, stent or not to stent. So what are the problems with the diffuse disease? Very likely we'll end up like this, a full metal jacket. So you don't need even a contrast to say where the circumflex, left main, LAD, bifurcation is. So this is a classic full metal jacket. Maybe in larger vessel, it's okay to consider full metal jacket. So for example, this was an RCS CTO, which was opened with a hybrid strategy. And you can consider putting a long layer of stent in a big artery. But even with that, if you look at, this is a paper I published on full metal jacket with drug-eluting stents, long-term follow-up, almost like a 5 years follow-up. You see the MACE rate is well over 30% at 5 years. And if you look at the TVR, it's almost 30%. Again at 5 years. So despite putting a stent in a larger vessel, over time you will end up having restenosis. How about diffuse disease like this? Small vessel, long lesions. You're calling for restenosis. And what are the risk factors for restenosis and thrombosis? So smaller vessel diameter, long lesion, long layer of stenting, and small reference diameter. But then if you add things like diabetes mellitus, chronic kidney disease, and severe calcification, your restenosis rate goes high. So we should avoid using full metal jacket in small vessels. So what are the options? The options are drug-coated balloons. Now, what are the advantages of drug-coated balloons over stents? One, it maintains the original artery anatomy. It gives you a homogeneous drug transfer. No restenosis or stent thrombosis because there's no metal or a polymer. And hence, you can also give them a short DAPT as low as 2 weeks. So leaving nothing behind is exciting, which is why the BVS or a bioabsorbable stents or scaffolds were invented, but we know where it is now. It's almost not used in most centers, although they're coming back. But you have to wait for 4 to 5 years for the scaffold to disappear. So with this, I would like to share some cases where we have used DCB. So where I work, we have a big Southeast Asian population in England. With high incidence of diabetes, and we're a big renal center, and we're also a big center for oncology, so which means we see a lot of high bleeding risk patients. So this is a 48-year-old lady, crescendo angina, diabetic on tablets, strong family history of coronary disease. Echocardiography shows some anterior wall hypokinesia. So the angiogram, as you can see, this was done in May last year. It's a subtotal occluded LAD involving a large diagonal and also a diffuse disease in the circumflex. So if you want to treat this with stents, very likely you will end up doing a full metal jacket, small stent, and if you add diabetes, which is diabetic, very likely in few years time she'll come back with restenosis or even a stent thrombosis, which is nightmare. So here we decided to do hybrid strategy. So we pre-dilated the lesion aggressively with non-compliant balloon, and in the diagonal we have to use a scoring balloon because it kept recoiling. And this is the post-predilatation. This is very important to assess what to do next. If you look at the whole LAD now, there is no flow-limiting dissection, there is no significant recoil. Probably there is some recoil in the diagonal and in the mid-LAD. So we used two drug-coated balloon, Magic Touch here, and we used one stent in the diagonal and in the proximal LAD. Circumflex again, we pre-dilated aggressively, and this is post-predilatation, which is very important to assess that there is no flow-limiting dissection or recoil. So we use again a two Magic Touch here, and this was the final result. So patient came back for a check angiogram at 4 months. At this point she was asymptomatic. As you can see, the results will look very good. There is a positive remodeling of the vessel. Because there was some recoil in the circumflex, we did the IFR, which was strongly negative. So essentially what we have done in this case is we have used only 2 stents for the whole left system. Let me show you another case. This is a 68-year-old man with angina, again risk factor diabetes. Angiogram of the right coronary artery showed some moderate disease in the main right coronary artery with some diffuse disease in the distal segment in the PLV and PDA branches. The problem in the left system was this: heavily diseased, diffuse, bifurcation in LAD diagonal and circumflex. So how would you treat this? Again, if you treat this with stents, you'll end up giving a full metal jacket. So we discussed him at the heart team meeting. Surgeons felt they can't graft this LAD due to diffuse nature. So plan was to embark the PCI with a hybrid strategy. So here you see the LED was not easy to cross. We had to use some CTO wires, but in the end we managed to cross. Then we again pre-dilated this aggressively, and this is a post-pre-dilatation. So if you can appreciate here, there is some dissection here, but again it is not flow limiting as there is no die hang-up and the TME3 flow. There is also dissection in the diagonal, but which we can accept this. So we used long magic touch and a stent at the top end, which is the proximal LED. So this was the final result. Now it's very tempting to put a stent here, okay? But I think we should refrain from this, and it comes with experience, because when we leave these kind of lesions, they come back nicely healed up later. The circumflex again was treated with aggressive balloon dilatation, and we used again 3 drug-coated balloons, and that's the final result. So check angiogram at 6 months. So this is interesting. So the dissection you saw there now is gone, and so as in the diagonal. The whole LED now is patent. I know it doesn't look like a stent-like result, but you have to refrain from stenting this because over time we see positive remodeling. So if you look at the post-procedure and the follow-up, you'll see the difference in the dissection and the positive remodeling. The third case, again, 52-year-old Asian gentleman with diabetes, with previous PCI to LED. His left system was okay, some moderate disease in the circumflex and the LED. I think the culprit here was the right coronary artery, which had significant disease in the distal segment and a subtotally occluded PDA. So this was crossed with a Corsair and a Fielder XTA, and we put a stent in the distal RCA, and we ballooned the PDA with a long balloon, and this is post-POBA. If you want to put a stent here, very likely use a 2 millimeter stent and maybe 60 or 80 millimeter length. So we used a 2.25 by 40 millimeter drug-coated balloon, and this is post-DCB. So you can accept this result because there is no significant recall. Now patient came back for an angiogram at 12 months because he had some chest pain, and you can see the PDA now. If you want, you can easily put a 2.5 millimeter stent here. So if you compare the two, post-DCB and 12 months follow-up, you can see the difference, how nicely the vessel has remodeled compared to what it was post-DCB and at 1 year. So the last case, 78-year-old gentleman with NSTEMI, new T-wave inversion. He had cabbage in 2015, Lima to LED and vein graft to obtuse marginal. RCA was patent, but he had, again, a diffuse disease in the PDA. So this was pre-dilated with a long NC balloon, and this is post-pre-dilatation. And again, like last case, we used a long DCB, and this is the final result. Again, it doesn't look great, but you have to resist the temptation to stent. Now, patient was not planned for a check angiogram, but he came back with chest pain 17 months later, and we did the angiogram, and you can see how nicely the whole PDA is perked up. So you can easily put a 2.5 millimeter stent if you have to. So again, if you compare the post-procedure and follow-up angiogram, you can appreciate the difference. So, in conclusion, diffuse coronary artery disease is a big challenge. Treatment with drug-coating stent will usually result in full metal jacket. Full metal jacket has a high risk of restenosis and stent thrombosis. DCBs are excellent alternative and maybe even the first choice for diffuse coronary artery disease, and we are doing a lot of registry and trials on this. Hopefully we'll have the results, but our initial results are very promising, so we should avoid putting stents in these small vessels. Thank you.